Welcome to the deep dive. Today, we're tackling coeliac disease. You've probably heard of it, maybe quite a bit, but perhaps don't have all the details clear. It
Mm,
can feel like a really dense topic, so our goal here is a clear, high-yield breakdown, perfect if you're revising.
absolutely.
So for you, the learner, listening in, this is about cutting through that noise, getting those key facts and maybe some aha moments without feeling swamped.
Good plan.
We've got some solid notes here as our base, and we're going to really explore coeliac disease properly, definition, causes, symptoms, management, the works, all geared towards helping you understand it and, crucially, remember it.
Exactly. In coeliac disease, it isn't just, avoiding a bit of bread. It's a significant autoimmune condition.
Mm,
So let's start right at the beginning, the definition.
okay.
Coeliac disease is an autoimmune disorder. The key thing is it's characterized by a permanent intolerance to gluten.
Okay, gluten. Let's pause there. What actually is gluten, and where is it typically found?
Right. Gluten's a protein. You find it mainly in specific grains,
Mm.
wheat, barley, and rye.
Ah, okay.
And importantly, it's usually present in most standard oats as well. That's often due to cross-contamination during milling, unless they are specifically certified gluten-free.
Got it. And how common is this?
It affects roughly 1% of the population, so not insignificant.
No.
And something else that's really interesting, clinically speaking, are the associations. We often see coeliac disease alongside type 1 diabetes, sometimes IgA deficiency, Down syndrome,
Yeah.
and there's definitely a familial link too.
Suggesting maybe shared underlying immune pathways or genetics?
Precisely. It points towards that interconnectedness within the body's systems.
So what actually causes this intolerance? What's the etiology?
Well, the exact trigger isn't fully pinned down yet. That's still an area of research.
Right.
But the general understanding is that it's a mix. You need genetic susceptibility. Specifically, the HLA-DQ2 and HLA-DQ8 genes are major players here, combined with an environmental trigger.
And that main environmental trigger we know about is gluten itself.
That's the one. Gluten exposure is the known environmental factor that sets it off in susceptible individuals.
Okay. So who is most likely to develop it? What are the main risk factors?
Yeah, the risk factors tie in closely with what we just discussed. A family history of coeliac disease definitely increases risk.
Makes sense.
And carrying those HLA-DQ2 or HLA-DQ8 genetic markers is a big one. Then, those conditions we mentioned, type 1 diabetes, Down syndrome, Turner syndrome, they also act as significant risk factors.
Right. So it's that combination, the genes you have, and then encountering gluten. Now let's get into the mechanism. What actually happens inside the body, the pathophysiology?
Okay, this is where it gets quite specific. When someone with coeliac disease eats gluten, it triggers an autoimmune response.
So the immune system reacts.
Yeah, it mistakenly sees gluten components as harmful. And this immune attack is primarily directed at the lining of the small intestine. This leads to what we call enteropathy, basically, damage or disease in the intestine.
And that's where the gut symptoms come from.
That's the origin for many of them, yes.
So the body's own immune system attacking the small bowel. What happens over time with that?
Well, with repeated gluten exposure, this ongoing inflammation damages the villi.
Ah, the villi, this tiny finger-like thing.
Exactly. They line the small intestine and are absolutely crucial for absorbing nutrients from food.
Okay.
This damage is called villous atrophy. The villi become flattened, blunted, sometimes they almost disappear. And the direct consequence of that is malabsorption.
Meaning the body just can't soak up the nutrients properly?
Precisely. Vitamins, minerals, fats, proteins. Absorption is impaired. And it's interesting, in children, this often becomes noticeable after they start eating cereals, which contain gluten, usually before they turn 3.
That fits with weaning, introducing solids. And you mentioned the genetics are strong here.
Very strong. Remember, the general population risk is about 1 in 100. But the link to HLA-DQ2 and DQ8 is powerful. Around 95% of people with coeliac have HLA-DQ2.
Wow, 95%.
Yep, and about 80% have HLA-DQ8. Now, these are the main genes, but it's a multigenetic condition. Other genes likely play smaller roles, too.
Huh?
And the family connection is significant. If you have a first-degree relative, a parent, sibling, child with coeliac disease, your risk is about 10–15%.
Much higher than the general population.
Definitely. And in identical twins, the concordance rate, meaning if one twin has it, the other does too, is around 70%. That really underlines the genetic component.
Yeah.
Clinically, this sometimes means we use HLA testing, perhaps, to assess risk in parents if their child is diagnosed.
Okay. So if someone comes in with symptoms that could be coeliac, what else needs to be on the differential diagnosis list? What could it be mistaken for?
That's a really important question because the symptoms can overlap with quite a few other conditions. We definitely need to think about Crohn's disease, another inflammatory bowel condition.
Right?
Irritable bowel syndrome, or IBS, is a common one to differentiate.
Hmm.
SIBO, small intestinal bacterial overgrowth. Also, a true wheat allergy, which is a different type of immune reaction, not autoimmune.
Okay, different mechanism.
Yes. And then there's non-coeliac gluten sensitivity. This is where people get symptoms from gluten, but they don't have the same autoimmune attack or the villous atrophy we see in coeliac disease.
That's a key distinction. Any others?
Sure. You might also consider lactose intolerance or other food intolerances, different types of colitis, including broader inflammatory bowel disease. And really, any other cause of malabsorption needs to be ruled out. It just shows why careful investigation is so essential.
Absolutely. Let's talk numbers then. How widespread is coeliac disease, the epidemiology?
So we said prevalence is around 1 in 100 people. But here's a really striking figure, the underdiagnosis rate. It's estimated that only maybe 10% to 20% of people who actually have coeliac disease have received a formal diagnosis.
So potentially millions undiagnosed.
That suggests a very large number are living with it unknowingly, yeah. And another interesting trend we saw, about a fourfold rise in the incidence, the rate of new diagnoses, between 1990 and 2011.
Fourfold. Wow. Any particular group?
The biggest jump was actually in the 50 to 69 age group.
That's surprising. Later onset, or just better detection later in life?
Could be a mix of factors, perhaps later onset in some, but also increased awareness and better diagnostic tests, leading to diagnoses that might have been missed before. Over the last 50 years or so, the overall increase in diagnosed cases is thought to be largely down to better diagnostics and more screening, especially in those high-risk groups we mentioned.
That fourfold increase is definitely something. Okay, so what does coeliac disease look like? What are the typical clinical features, especially thinking about children first?
In kids, you're often looking for things like chronic diarrhea, tummy pain, bloating, maybe weight loss or poor weight gain. Anemia is common, fatigue too.
Nutrient deficiencies?
Yes, definitely watch for low vitamin D, iron, B12. And because of the malabsorption, you can see growth problems, even delayed puberty.
Right.
Think about that classic triad, especially in younger kids, soon after gluten is introduced. Failure to thrive, diarrhea, and a distended, bloated abdomen.
Okay, key signs there.
And in slightly older children, sometimes unexplained anemia is the main clue.
Right. What about presentation in adults, or if it's missed in childhood?
Well, remember, many people aren't diagnosed until they're adults. It really can present at any age, even infancy sometimes.
Okay.
General symptoms often include that chronic diarrhea, maybe pale, floating stools, it's called steatorrhea, due to malabsorption. Fatigue is huge. Poor growth is diagnosed later.
Right.
And there's a specific skin condition strongly linked to a dermatitis herpetiformis. It's this really itchy rash with blisters.
So not always gut symptoms.
Exactly. Which is why screening high-risk people, even without obvious gut issues, is so important. If it goes undiagnosed for a long time, later symptoms can emerge like ongoing poor growth, developmental delay in kids, persistent anemia, even joint pain.
It sounds quite systemic, not just a gut issue.
It absolutely is.
Right.
Untreated coeliac disease can impact multiple organ systems. We even see neurological links.
Neurological? Like what?
Things like cerebellar ataxia, problems with balance and coordination, neuropathy, which is nerve damage, epilepsy, dementia, even depression have been associated.
Wow. So neurological problems could even be the first sign.
In some cases, yes. These broader neurological syndromes can sometimes be the initial presentation, which can make diagnosis tricky.
And does going gluten-free help those neurological symptoms?
The results there are quite variable, unfortunately. Some people see improvement, others don't. It adds another layer of complexity.
Okay. So faced with these possible symptoms, how do doctors actually pin down the diagnosis? What are the key investigations?
Right. The diagnostic pathway usually starts with blood tests. We're looking for specific antibodies that the body produces in coeliac disease.
Which antibodies are those?
The main ones are anti-tissue transglutaminase, usually called anti-TTG, and anti-endometrial antibodies, or EMAs. We typically test for the IgA type of these antibodies.
Okay, blood tests first. Then what?
If those blood tests are positive and suggest coeliac disease, the definitive confirmation, the gold standard, is a biopsy of the small intestine.
A biopsy? How is that done?
It's usually done during an upper endoscopy. A camera goes down, allows the doctor to see the lining of the duodenum, the first part of the small intestine, and take tiny tissue samples.
Okay. Now, there's a really crucial point about diet during testing, isn't there?
Absolutely critical. You must keep eating a normal gluten-containing diet throughout the entire testing process, blood tests and biopsy.
Why is that so important?
Because if you start a gluten-free diet beforehand, the antibodies in the blood can disappear, and the damage in the gut lining, the villous atrophy, can start to heal.
So the test would look falsely negative.
Exactly. You could miss the diagnosis completely. So a key message for anyone undergoing testing is don't ditch the gluten until the specialist tells you to. Maybe think no gluten-free before the B&B's, bloods, and biopsy.
Okay, good way to remember it. What specific blood tests are ordered?
The standard first-line approach for young people and adults is to check total IgA levels and IgA anti-TTG.
Why total IgA?
Because a small number of people with coeliac disease also have an underlying IgA deficiency. If their total IgA is low, their IgA-TTG test could be falsely negative.
Ah, I see. Good point.
So you check total IgA first. If IgA-TTG comes back weakly positive, sometimes IgA-EMA is checked, as it's considered very specific, though maybe slightly less sensitive.
And if someone is IgA deficient?
Then you need to use different tests.
Yeah.
You'd consider Ig-based tests like IgG-EMA, IgG-DGP, which stands for deamidated gliadin peptide, or IgG-TTG.
Okay, so adapt the tests based on IgA status. Then the biopsy confirms it by looking for those characteristic changes.
Yes. The pathologist looks under the microscope for those key features. The villous atrophy, flattened villi, crypt hyperplasia, the pits between villi get deeper, and an increase in intraepithelial lymphocytes, more immune cells within the gut lining. You often need multiple biopsies from different sites because the damage can be patchy.
And what about those newer guidelines for adults you mentioned earlier?
Yes. There's been a shift recently. For certain adults, typically those under 55, with very high levels of IgA-TTG, like more than 10 times the upper limit of normal, confirmed on a repeat test, and who have positive EMA results and have symptoms, some guidelines now suggest that a diagnosis can potentially be made without an immediate biopsy.
So a no biopsy diagnosis in some cases.
Potentially, yes. It aims to speed things up for clear-cut cases. However, and this is important, a biopsy is still needed for many patients. If there's any doubt, if the antibody levels aren't that high or in older adults, biopsy remains essential.
And just to hammer it home.
Keep eating gluten throughout all testing, yes.
Okay, so investigations recap, full blood count, check total IgA and IgA-TTG, plus EMA maybe, or IgG tests if needed, and then usually endoscopy with multiple biopsies unless someone meets those very specific no biopsy criteria. And keep eating gluten. When should a referral happen?
Pretty clear guidelines here. Anyone suspected of having coeliac disease based on symptoms or initial tests needs referral to a gastrointestinal specialist for that endoscopic biopsy to confirm or exclude it.
Right.
Children with positive blood tests should definitely see a pediatric gastroenterologist. And importantly, even if the blood tests are negative, if you still have a high clinical suspicion based on the person's symptoms and history, a referral for further assessment is still warranted. Don't just stop if the bloods are negative but the story fits.
Good advice. Okay, so we've got the diagnosis confirmed. What's the management plan? What's the treatment?
The absolute cornerstone, the primary and lifelong treatment, is a strict gluten-free diet, GFD.
Right.
That means completely cutting out all foods containing wheat, barley, and rye. And as we said, usually oats too, unless they are certified gluten-free because of that cross-contamination risk.
A mnemonic for that.
You could think WBR, NO, wheat, barley, rye, and usually NO oats unless certified GF.
WBRNO. Got it. That sounds like a huge lifestyle change. Lifelong. It is. And that's why support and education are absolutely vital. Specialist dietitians with expertise in coeliac disease are key members of the management team.
What kind of education is needed? It's comprehensive. Patients need to learn how to identify safe foods, how to find gluten-free alternatives, how to meticulously read food labels to spot hidden gluten. It can be in sauces, processed meats, medications even.
Wow, yeah.
They need practical tips for eating out, social events, traveling. And learning how to prevent cross-contamination at home is crucial. Separate chopping boards, toasters, utensils, checking shared condiments.
Sounds like a lot to manage.
It is initially. That's where coeliac support groups, national and local ones, can be incredibly helpful. Peer support, sharing tips, getting reliable information.
What about supplements? Are they generally needed?
It's best to get healthcare advice before taking lots of over-the-counter things. But yes, especially early on after diagnosis, supplements like calcium and vitamin D might be needed to correct deficiencies caused by the previous malabsorption.
Okay. And those gluten-free oats, can people eventually eat those?
Some can, yes. Once the gut has healed and symptoms are controlled, many people can tolerate certified gluten-free oats. But it's usually introduced carefully under guidance to monitor for any reaction.
How do you monitor someone long term? Do they need repeat biopsies?
Regular follow-up is important. A repeat biopsy isn't usually routine if someone is doing well on the diet, but it might be considered if their antibody levels, like TTG, stay very high after, say, 12 months on a strict diet, or if symptoms persist despite them being sure they're avoiding gluten.
What happens at the annual checkup then?
Usually involves checking weight and height, especially crucial in children, asking about any ongoing symptoms. A careful dietary review. Are they managing okay? Are there any hidden gluten sources? Sometimes a DXA scan is considered to check bone density, especially if diagnosis was delayed or there are other risk factors for osteoporosis.
Right.
And you're always assessing for potential complications, looking for related conditions, comorbidities,
Yeah.
and seeing if they need referral to any other specialists.
What if someone just doesn't get better on the gluten-free diet?
That's what we call non-responsive coeliac disease, or sometimes refractory coeliac disease if it's really persistent. First step is always to double-check the original diagnosis was correct. Then a referral back to that specialist dietitian is crucial. They'll do a deep dive into the diet to find any accidental gluten exposure. It's often unintentional contamination. You also need to look for other things, maybe lactose intolerance developed, or IBS, or SIBO, or even complications of coeliac disease itself.
And refractory coeliac.
That's diagnosed when you're sure they're not getting any gluten, you've ruled out other causes, but they still have persistent symptoms and gut inflammation. These are complex cases, usually managed in specialist centers.
Is there medication for that?
Sometimes for adults with refractory coeliac disease, steroids like prednisolone might be used initially to control severe symptoms. But it's important to stress there's no drug cure for coeliac disease itself.
Right.
The GFD is the treatment. Supportive meds are things like iron, vitamin D, calcium, just to replace what's missing.
Any other treatments? What about a coeliac crisis?
That's a rare but severe presentation, sometimes seen at initial diagnosis, especially in infants. It involves severe diarrhea, dehydration, electrolyte problems. Management is supportive IV fluids, sometimes corticosteroids, correcting electrolytes. But again, the underlying treatment is removing gluten.
Can people get gluten-free foods prescribed?
Yes, in some parts of the UK, certain gluten-free staple foods like bread and flour mixes can be prescribed on the NHS, which helps with the cost, as they can be expensive.
That's useful. And does sticking to the diet reduce long-term risks?
Yes, definitely. Good control through the GFD significantly reduces the risk of developing complications like certain types of gut cancer, adenocarcinoma, and lymphomas. Monitoring usually involves checking those TTG antibody levels. Periodically, they should come down and stay low on a strict diet. And in children, tracking growth is key.
So overall, what's the outlook, the prognosis for someone diagnosed?
Generally, it's excellent, provided they stick rigorously to the gluten-free diet. Yes. Most people find their symptoms improve dramatically, they feel much better, and they can achieve a completely normal life expectancy. But that lifelong strict adherence to the GFD is absolutely essential. That's the key to preventing complications and staying healthy.
Okay. Let's talk about those complications then. If it's untreated or not managed well, what are the risks?
There are several potential long-term issues. Osteoporosis and poor bone health are significant concerns, often linked to that delayed diagnosis and chronic lack of calcium and vitamin D absorption.
Right, makes sense.
There's an increased risk of certain cancers, particularly cancers of the gastrointestinal tract and lymphoma, though the exact level of overall increased cancer risk is still debated in research.
All right, what else?
Other potential problems include something called ulcerative jejunitis, which is severe inflammation and ulceration in the small bowel, functional hyposplenism, where the spleen doesn't work properly, increasing infection risk. Also, higher rates of anxiety and depression have been reported.
And pregnancy, fertility.
Yes, untreated coeliac disease is associated with problems in pregnancy, poorer fetal outcomes. It can also be linked to infertility in both women and men. The good news is that fertility often improves significantly once a strict gluten-free diet is started.
That's positive. Any specific challenges for teenagers?
Adolescence can be a tough time for adherence. Social pressures, wanting to fit in, can make sticking to a very strict diet difficult.
Yeah, I can imagine.
And poor adherence during those crucial years can lead to ongoing nutritional deficiencies and impact bone density accrual. Though again, improving diet adherence later can help recover bone health.
Wow. Okay. That's a really thorough walkthrough of coeliac disease, from the basic definition right through to long-term management and potential pitfalls. It definitely feels less dense now.
Good. The main message really is, it's a significant autoimmune condition, yes, with potentially widespread effects if ignored, but effective management is achievable. That strict gluten-free diet is incredibly powerful.
And getting the diagnosis right in the first place with the proper tests, bloods, and biopsy usually is critical.
Absolutely crucial. Timely and accurate diagnosis is step one.
Okay. So to leave our listeners with something to chew on, here's a final thought. We talked about that rising incidence and the fact that so many people might be undiagnosed. What does that mean for public health? Should we be thinking more about awareness campaigns or even broader screening strategies, perhaps in high-risk groups? Definitely some food for thought there.
Important questions.
And if you are revising or want to explore more resources, don't forget to check out pastthemsra.com and freemsra.com. Thanks for joining us for this deep dive.